Live from Atlanta, Georgia, I'm Emilio Madrigal. Today I'm joined by my good friend and colleague, Rifat Manan, who is alongside Dr. Ashley Marie Chimino-Matthews in Baltimore, Maryland. Dr. Chimino-Matthews is the director of the breast pathology program at Johns Hopkins, and today she will present breast spindle lesions. Before we get started, I want to point out the Pathology Education for Clinicians website maintained by the Department of Pathology at Johns Hopkins, where you can find numerous resources and educational opportunities. You can access the website by using the link that's being shown on your screen now, and we'll also post a link to this website at the end of the lecture on our social networking sites as well as our website. As always, you are more than welcome to ask questions by typing them as comments right here in the Facebook Live and YouTube watch windows, and I will make sure to pass those questions along at the end of the session. So with that, I will now turn the microphone over to Dr. Chimino-Matthews. Thank you.
Thank you, Emilio. Thank you all for joining us this afternoon. It's really a pleasure to present this topic of breast spindle cell lesions. Thank you both, Rifat and Emilio, for the invitation. I love this topic of breast spindle cell lesions, as difficult as it is diagnostically, but because it's so varied and the variety of the differential diagnoses in the entities really ranges depending on whether you have bland spindle cells or markedly pleomorphic spindle cells. So we'll look at a few of the key examples today. So I'd like to start off by saying the number one entity that you need to exclude when you see a spindle cell lesion in the breast is a metaplastic carcinoma or a sarcomatoid carcinoma. Now, often metaplastic carcinomas, as seen here, aren't difficult to diagnose when you have an epithelial component associated with them. In this particular example, we see a focus of high-grade DCIS accompanied by a very pleomorphic, wildly atypical infiltrating neoplasm. So this is an invasive metaplastic or sarcomatoid carcinoma with pleomorphic features. As you know, metaplastic carcinomas can show a variety of heterologous differentiation, including, as seen here, the pleomorphic spindle cells. We can also see chondroid differentiation, as seen in this particular example. We can see epithelial type differentiation that is squamoid or squamous. And in these particular examples, it isn't so difficult to make the diagnosis of metaplastic carcinoma because these epithelial components are overtly present on the H&E sections. Where it can be more difficult to recognize or make the definitive diagnosis in metaplastic carcinoma is when you have otherwise nondescript spindle cells, as we see here in this particular example. Here we see in this breast tumor sheets of pleomorphic and atypical spindle cells with brisk mitotic activity. And in isolation, this field of cells brings up a wide differential diagnosis. Is it metaplastic carcinoma, malignant phylloides tumor, primary breast sarcoma, metastatic sarcoma to the breast? A melanoma enters the differential, as do certain hematologic malignancies. So really the differential is quite broad. Often, the key way to diagnose a metaplastic carcinoma is if you take additional samples and see that you have an associated epithelial component. As we see in this particular example, adjacent to the spindle component, we have a overtly epithelial ductal carcinoma. So in the examples I've provided so far, whether it's the presence of overt epithelial differentiation, an accompanying in situ component, or other heterologous elements, these are features we can use just on the H&E to help us make the diagnosis of a metaplastic carcinoma. Where it gets particularly challenging, and I'd say interesting in terms of the discussion we'll have today, is when we're dealing with bland or low-grade spindle cell proliferations. Here's an example on core needle biopsy of a breast mass, which from low power shows varying regions of cellularity, some rather hypocellular, as seen here. In the center, we have a benign duct. as we scan the core, we can see some areas are more cellular, but still, from low power, the cells appear fairly bland. As we go to higher power, we can appreciate there is some nuclear atypia. And from even higher power, we can see more nuclear irregularity. Pause here for a minute. Now, in this example, this core biopsy contains exclusively spindled cells, no epithelial component. And in isolation, any one of these fields could be described as reactive appearing myofibroblasts. As you continue along the cores in the more cellular areas, you see nuclear angulation, some nucleoli, and increased atypia. So here, the differential diagnosis is no longer the same as in the previous examples with the high-grade pleomorphic undifferentiated cells. Now we're entering the land of the bland spindle cell proliferations. The primary differential diagnosis in this particular lesion is a spindle cell metaplastic carcinoma, also termed fibromatosis-like metaplastic carcinoma. And, as that name would imply, the differential thus includes fibromatosis, which we'll take we'll look at shortly. So when you have a core needle biopsy of a bland spindle cell proliferation in the breast such as this, the first thing you need to think about doing are cytokeratins. Fibromatoses of the breast, as in other sites of the body, are not immunoreactive for cytokeratins. In this particular example, cytokeratin immunostains are performed. I have them here. This example shows a CK903 antibody, and you can see here that many of these cells label for cytokeratin, perhaps more so than you would have appreciated on the H&E alone. But you can see even in the relatively hypocellular areas, there are still cytokeratin positive cells. We can appreciate that here on higher power. Again, fibromatosis of the breast will not display cytokeratin positivity. I will note at this time that some metaplastic carcinomas, particularly the high-grade undifferentiated pleomorphic ones, don't label for any given single cytokeratin antibody, or sometimes they may not label for any cytokeratins because they're so undifferentiated. We always do a panel approach with our immunostains and evaluating for metaplastic carcinoma. So we would never do one cytokeratin antibody alone. Typically we'll do CK903, A1A3, and CAM 5.2 to hit kind of low and high molecular weight cytokeratins. And it's not uncommon for a metaplastic carcinoma to only label for one of the particular cocktails. Now, the other immunostain that can be useful in this bland spindle cell differentiation is beta-catenin. And beta-catenin is typically used to support a diagnosis of fibromatosis. So nuclear labeling is seen in the majority of fibromatoses. We do it in this setting, even in this differential of fibromatosis like spindle cell metaplastic carcinoma, and the majority of cases indeed are negative for nuclear beta-catenin labeling. So you see some background cytoplasmic labeling, but the arrow is indicating the nuclei. I guess I'll point to some of the large ones are negative for nuclear beta-catenin labeling. There is a potential diagnostic pitfall in using beta-catenin in spindle cell lesions of the breast, if it weren't already confusing enough. Approximately 20 to 25% of the spindle cell metaplastic carcinomas will show nuclear beta-catenin labeling. That nuclear beta-catenin labeling just indicates aberrations in the APC gene pathway. So you can have nuclear beta-catenin accumulation in tumors besides the fibromatoses or the desmoid tumors. So nuclear beta-catenin labeling alone is not sufficient to make the diagnosis of fibromatosis here in the breast. You must do the cytokeratins to exclude the low-grade spindle cell metaplastic carcinoma. One of the other antibodies we typically use in the panel of evaluating a spindle cell lesion of the breast on core needle biopsy is CD34, which I'll show here. Metaplastic carcinomas of the breast are CD34 negative. So why is that important? A few reasons. Here's the CD34 immunostain, and you can see that the 34, I like to find my arrow, highlights the blood vessels, but the lesional cells in between the vascular spaces are 34 negative. There are two reasons we use the CD34 in this differential. One is if we're concerned about a phylloides tumor. CD34 labels the stromal cells of phylloides tumors. I'll get to that more later. And CD34 also labels Myofibroblastomas, which we'll also look at today. However, as I said, metaplastic carcinomas are negative for CD34. So the absence of beta-catenin labeling, the absence of CD34 labeling, and the positive labeling for several cytokeratins helps make the diagnosis, in this particular case, of a spindle cell fibromatosis like metaplastic carcinoma. And this really is the primary diagnosis that we try to exclude every time we see a bland spindle cell proliferation of the breast. I'd like to take a look now at an example of an actual fibromatosis involving the breast, so we can compare and contrast the features. Here's a core needle biopsy of a breast mass in a young woman. Now, fibromatoses in the breast look histologically identical to fibromatoses elsewhere in the body. The fibromatoses that involve the breast are typically not syndromically associated, so they're typically sporadic. There are reports of fibromatoses occurring after surgery or in association with breast implant capsules. This particular patient doesn't have a history of any of those things. Histologically, the fibromatosis is a very nice example. It's comprised of bland spindled cells that may have a fascicular pattern, and the spindled cells themselves are hypochromatic relative to the endothelial cells. So what does that mean? That means that the lesional cells have paler chromatin than the endothelial cells. And endothelial cells in this lesion, well, they're benign, so they serve as a kind of an internal control of what a benign nucleus may label as. Other features that you'll commonly see in fibromatosis are this small white space, this gap between the blood vessel and the lesional cells. If fibromatosis in the breast as in elsewhere is an infiltrative lesion, so local control is really imperative in these cases to prevent recurrence. So you can see here the spindle cells infiltrating. So radiographically, fibromatosis can mimic a carcinoma, and histologically can both mimic a carcinoma, metaplastic carcinoma, as well as even just scar, depending on what area of the lesion you have. If you don't see an infiltrative component, these cells are very bland, and it could certainly be scar. So as another feature I might mention as I'm here, in fibromatosis, you sometimes see these lymphoid aggregates. Now, fibromatosis in the breast, as I said, will be negative for cytokeratin. So this is an example of one. This is CAM 5.2. You nicely see the ductal epithelial cells labeling, and although pale in the contrast here, the lesional cells are negative for keratins. In contrast, this particular case does have a beta-catenin immunostain associated with it. And what you're looking for in the beta-catenin immunostain is true nuclear labeling. So let me see if I can get my arrow right there for you. So this lesion does have nuclear beta-catenin labeling. So the morphology, the lack of keratin labeling, and the nuclear beta-catenin labeling all support a classification of this gland spindle cell lesion as a fibromatosis, an extra-abdominal desmoid tumor. Other pertinent negative immunostains in these bland spindle cell lesions would also include S100, primarily for peripheral nerve sheath tumors, but also occasionally desmoplastic or epithelioid appearing metastatic melanomas. And as I said, CD34 is often one we do in this setting, and it is negative in fibromatosis. The other entity that I've mentioned so far in the differential of bland spindle cell lesions in the breast is a myofibroblastoma. So I'm going to move on to talking about myofibroblastomas now. Not all myofibroblastomas show spindled morphology, but they can. Myofibroblastomas are neoplastic proliferations of the stromal cell of the breast, the myofibroblast. And this is a really beautiful, histologically classic example. I just love these tumors, they're so pretty. We see let me get a nice field for you. We see the lesional cells in this particular example are epithelial. The cytoplasm is amphiphilic, so it's kind of in between pink and blue. It's with a pale purpley color. Some of the cells show this nesting appearance, and some show cording. And there's this brightly eosinophilic pink collagen associated with the cells. As we go to 1 power higher, we can see that there's fairly uniform pale chromatin with punctate nucleoli. Some of the cells show some grooves. And again, the cells, for the most part, have indistinct cell borders. Myofibroblastomas are typically well-circumscribed lesions that do not infiltrate between benign ducts and lobules. So you can see a fairly demarcated border to this lesion. It used to be thought that myofibroblastomas occurred preferentially in male breast tissue, but those reports are kind of before the mammographic screening era, when the lesions were being detected as palpable masses. Myofibroblastomas can basically occur equally in men and women. And as in extramammary soft tissue myofibroblastomas, these lesions often carry deletions in chromosome 13, Q14, and this particular region of the chromosome carries the gene for retinoblastoma protein, so RB protein. So that's a characteristic feature in these lesions. Immunohistochemically, as I mentioned, myofibroblasts of the breast label for CD34, as well as ER, and we'll talk about how that could be a potential pitfall in a minute. The myofibroblastomas can also label for desmin BCL2. Important pertinent negatives are that they're negative for S100 and negative for cytokeratin. So let's take a look at a few other examples that aren't so histologically classic in appearance. All right. So here's a core needle biopsy, so we're in focus, of a breast mass in a female patient. And we can see that the lesion is comprised of fairly bland epithelioid to spindle cells that seem to stream along with some semblance of pink collagen. Now, this lesion almost has areas reminiscent of nuclear palisading that you see in schwannomas, so peripheral nerve sheath tumors that show the Verrier bodies of the nuclear palisade. And indeed, schwannoma is in the differential of a lesion with this morphology. So now we're in between a differential of an epithelioid neoplasm and a spindle cell neoplasm. As we've, just to reiterate, differential diagnosis of these bland spindle cell proliferations first and foremost need to exclude metaplastic carcinoma, then consider fibromatosis, myofibroblastoma, and other less common entities like the nerve sheath tumors, nodular fasciitis, and sampling of a stromal component of a pyloides. So in this example, the cytokeratin are performed, and AE1, AE3 is negative in the lesional cells, and I don't actually have benign lobules to show you as an internal control, but the lesional cells are negative. CD34 is then performed and is positive in the lesional cells. You say, wait, CD34, doesn't that make it a vascular lesion? That's an important thing to consider, but these cells are CD34 positive and negative for CD31 and ERV. So they're not vascular cells, they're not endothelial derived. These are the stromal cells of the breast. So CD34 is positive. If you did it at 31, would be negative. And then we have ER. This is really brings up an interesting differential. And you can see here that the lesional cells show labeling for ER. What might be the problem of having ER labeling in a dense, sort of a cellular epithelioid lesion in the breast? You might mistake this for an infiltrating carcinoma that's ER positive. In particular, if you look back at the original lesion that I showed of a classic myofibrilblastoma, in some areas the cells seem to single file and look rather plump and epithelial, and taken in isolation, the differential certainly could be an invasive lobular carcinoma. And if that's your leading differential and you put an ER immunostain on it, it'll be positive. That's a potential diagnostic pitfall in only performing one antibody on a lesion such as this, and not including a broad differential when you're trying to decide where to go with the lesion. So take home points for this particular case with spindle cells, CD34 positive, ER positive, cytokeratin negative. This supports classification as this lesion as a myofibroblastoma. Another example of a myofibroblastoma on core needle biopsy is here. And I show these different examples to show you both the classic pattern, but then some variant patterns, because these are what we'll encounter in everyday core biopsies. This lesion has bland, nondescript spindle cells, some hint of collagen. Some of the nuclei, really, they're quite elongated and maybe even wavy to make you think about a peripheral nerve sheath tumor like a schwannoma. There are scattered plasma cells here, and if I wanted to, I could find a mast cell to make me think about a neurofibroma. And in some areas, the stroma becomes even more myxoid in appearance, with loose collagen fibers, again, raising the differential of a peripheral nerve sheath tumor. And in fact, let me move the field here because, as I promised you, I could find a mast cell. In some of these examples, you'll also see hyalinized blood vessels. If it weren't complicated enough, these hyalinized blood vessels also are a feature that raises the possibility of a peripheral nerve sheath tumor. So how can we make the distinction? Well, first, always have a broad differential in your mind. As soon as you see a core biopsy like this, we think, okay, make sure it's not metaplastic carcinoma. Is it a fibromatosis? Well, the nuclei and the blood vessels aren't quite right. Could it be a myofibroblastoma, given that that's the spindle cell of the breast? And bring into your differential a peripheral nerve sheath tumor. They're rare in the breast, but they certainly do occur, both in the breast parenchyma as well as along the chest wall or in the axilla. They occur in both men and females. So in this particular case, an S100 was performed, and the lesional cells are S100 negative, arguing against a diagnosis of a peripheral nerve sheath tumor. You see scattered dendritic type cells labeling. This case I brought to show BCL2 labeling. So this is not specific. BCL2 does label other entities, but you can see nice BCL2 labeling in Myofibroblastomas. And lastly, importantly, the ER shows nice diffuse labeling. This constellation of features again is S100 negative, BCL2, CD34, and ER positive. I'll also note that Myofibroblastomas can show various variable labeling for smooth muscle markers such as Desmond, and we can show you here. We do see some Desmond labeling. So that's what I want to say right now about the bland spindle cell lesions in the breast. We looked at spindle cell metaplastic carcinoma, fibromatosis, and myofibroblastomas for now. I'd like to shift gears and talk about the other overarching entity that we need to consider in spindle cell lesions of the breast, which are my other favorite class of lesions, the phylloides tumors. So just like in metaplastic carcinomas that I showed at the beginning, when the histologic features are well developed on the H&E, immunostains are not always necessary. And in many cases of phylloides tumors, we have the diagnostic features on the H&E. It's when it's purely spindled or you're handling a small sample size on a core biopsy that immunostains may be needed, or the differential or the diagnosis may be equivocal. Phylloides tumors, as you know, are fibroepithelial lesions of the breast. So they have both the stromal, the fibrous component, and the epithelial component. The stromal cells are the neoplastic cells. And we subdivide phylloides tumors into benign, borderline, and malignant on the basis of a constellation of features, including circumscription, the degree of stromal cellularity, presence or absence of stromal overgrowth, stromal cell atypia, mitotic rate, and the presence or absence of heterologous elements. Phylloides tumors are such an interesting class of tumors because the differential, again, varies so greatly between the benign end and the malignant end. The differential of benign phylloides is a fibroadenoma. So those are rarely coming into consideration when we're talking about a purely spindle cell lesion of the breast, because they commonly have the epithelial component. On the other end of the spectrum, we have malignant phylloides tumors, as in the one seen here. We see marked cytologic atypia in the stromal cells, frequent mitotic activity with atypical mitoses, and variation in the stromal cellularity from less cellular to more cellular. Now, when you have the overt leaf-like component of the phylloides tumor, it's straightforward in making the classification as a phylloides tumor. As we see in this example here, it's quite evident that we have abundant leaf-like architecture. In some cases, the leaf-like architecture may be less evident. Here's an example of a breast mass on excision. When we look at this area, this is one low power field, so 4x field, which by definition is stromal overgrowth, and we have zones and zones of what would be called stromal overgrowth in a phylloides tumor. From low power, we see these sheets in some areas fascicular of these spindled cells. They are atypical, but not markedly pleomorphic. They're fairly uniform. And mitotic activity is not difficult to identify. So this alone certainly raises the differential of a metaplastic carcinoma, particularly as we've seen the spindle cell metaplastic carcinoma. As we scan the lesion, we see an abrupt transition between the spindled component and this hyalinized fibroepithelial area. So the presence of this hyalinized lower grade component with leaf-like architecture helps us classify this lesion as a malignant phylloides without worrying about immunostains and having to exclude metaplastic carcinoma on another basis. This illustrates the importance of adequate sampling in breast tumors. Sometimes the most useful thing is going back to the bucket and putting in more sections. This next example of a malignant spindle cell tumor here on excision, you just see sheets and sheets of high-grade pleomorphic cells. This is in contrast to the last case where the cells were more uniform and moderately atypical. But here we see these cells, which you could even argue look epithelioid in areas. We have multi-nucleation, atypical mitotic figures. Again, this is these giant malignant cells. And if this were the only section we have with a lot of necrosis in these atypical cells, it's very difficult to make a definitive diagnosis. Additional sections of the same lesion show areas, again, with overtly leaf-like architecture and lower grade component, which helps support the classification of this entire lesion as a malignant phylloides tumor. So I'm using these cases to illustrate how the presence of leaf-like architecture in a spindle cell lesion alone helps support phylloides tumor, whereas in the first set of cases we looked at, the presence of overt epithelial components such as the squamous cell component or abundant DCIS or a poorly differentiated ductal carcinoma, those components will favor classification as a metaplastic or sarcomatoid carcinoma. Okay. Let's go back to look at these this example here that has these sheets and sheets of bland spindle cells. The question is, what do you do when you get this on core needle biopsy? And that's what we get on core needle biopsy. The challenge with core needle biopsy in all of these lesions, whether it's metaplastic carcinoma or a phylloides tumor, is sampling. You're getting about the spaghetti noodle diameter of sampling of this mass that may be 6 centimeters or more in size. And if all you get are the spindled cell component, you may not have the histologic clues to help you with the overt diagnosis. Phylloides tumors, as I mentioned, are often immunoreactive for CD34, which is what we see here. Remember that the metaplastic carcinomas are CD34 negative. Again, the other entity that I showed you that was CD34 positive so far were the Myofibroblastomas. And to me, this makes sense because this neoplastic cell of origin in the phylloides tumors, the breast stromal cell, again, myofibroblastic. CD34 is helpful if it's positive. About almost 100% of the benign and borderline phylloides tumors are CD34 positive. So that's great, except the stromal overgrowth and expansile spindle cells are often seen in the malignant phylloides. Only about half of the malignant phylloides tumors are CD34 positive. Right? So if CD34 is negative, it does not exclude a malignant phylloides tumor. But if it's positive, it certainly can help you favor a phylloides tumor over a metaplastic carcinoma. I want to bring up one major caveat and pitfall when we're looking at phylloides tumors and keratins, because this is an area of, I think, shifting opinions. So this case I've hopefully clearly demonstrated to you is indeed a malignant phylloides tumor. We have 34 labeling. We have an overt low-grade component. And lo and behold, CAM 5.2 actually labels the stromal cells. This can be focal or it can be rather diffuse. And this can happen with CAM 5.2 or AE1, AE3. So malignant phylloides tumors can show cytokeratin and P63 labeling in the stromal cells. Previously, the paradigm was, if you have any keratin labeling, you can call it a metaplastic carcinoma. We've shown that that just isn't the case, because in histologically classic malignant phylloides tumors, you can see keratin labeling. Why is that? Well, these are malignant cells which are differentiating in all different ways, and they're likely aberrantly expressing these keratin proteins. Why do I make a fuss about this? Because on core needle biopsy, if you have that bland spindle cell proliferation, which looks like this with some atypia, and you just do a keratin alone, and you have some focal labeling, that is not enough to call it a metaplastic carcinoma. You cannot exclude a phylloides tumor on the basis of some keratin labeling. Now remember, this has to be taken in context with other histologic features, other immunostains such as CD34, etc. But this is a potential diagnostic pitfall, particularly on the limited sampling of a core needle biopsy. The last thing I will say about phylloides tumors is, as I mentioned with metaplastic carcinomas, phylloides tumors can also label for nuclear beta-catenin. This is even more of an issue in phylloides tumors than in metaplastic carcinomas, because upwards of 70% of malignant phylloides will show nuclear beta-catenin labeling. So again, we do beta-catenin labeling to support a diagnosis of fibromatosis in the correct histologic setting, but nuclear beta-catenin labeling alone does not make a lesion of fibromatosis. And I'm talking particularly in the breast here, where our differential includes metaplastic carcinoma and phylloides tumors. It's obviously different in soft tissue sites. So far we've looked at metaplastic carcinoma, fibromatosis, myofibrilblastoma, and looked at malignant phylloides tumors. I do have a few other spindle cell lesions we can look at, but given that it's a quarter till, I'll ask Rifat now if we have any questions already coming in, and if so, we can take some time to do those now.
Thank you, Dr. Sabina. There is one question, but it's more of a comment coming online, that someone is commenting that myofibroblastomas can also express androgen receptor.
Yes, that's true. That's a great comment. Myofibroblastomas can also express the androgen receptor, AR, and that can be a useful finding, although it's not mutually exclusive of other diagnoses. But yes, that is true, and it can be helpful.
That's the only question about
yeah.
we have so far.
The one thing I'll say about androgen receptor labeling in myofibroblastomas is that in a male breast, the differential of any lesion in the male breast includes a primary mammary carcinoma. The number one metastasis to involve the male breast is prostate carcinoma. And of course, you can see benign lesions such as myofibroblastomas. Androgen receptor will be positive in prostate cancer, so just keep in mind the histology when you're making the diagnosis. And I will note again that myofibroblastomas are benign, but when we see them on core needle biopsy, they're typically excised because the long-term outcome of leaving them in hasn't been established. Okay, so are there any other questions at this time? Okay, that's great. So let's move on and look at another tumor that has a classic morphology, but can show a spindled form. And that tumor is seen here. Now, we are actually in breast parenchyma. I can prove that to you because I see breast lobules here. And then I see some unauthorized cells, and we have to figure out what these cells are. So I see these nests of cells with abundant pink cytoplasm, which you might actually describe as granular. The cells have indistinct cell borders, fairly bland nuclei with occasional punctate nuclei in this particular example. The differential diagnosis of cells, and I should note also they have an infiltrative pattern of cells with abundant foamy or granular cytoplasm in the breast, includes histiocytoid lobular carcinoma, histiocytes or fat necrosis, and this entity, which is a granular cell tumor. Granular cell tumors occur in different locations in the body. They're rare in the breast parenchyma, but they do certainly occur. And they can also occur in the breast post-surgically, such as in mastectomy sites. Granular cell tumors in the breast label like granular cell tumors elsewhere in that they're S100, CD68, and inhibin positive. Importantly, they're keratin negative, so we can exclude a histiocytoid lobular carcinoma. So although they overlap with histiocytes with the CD68 labeling, it's the S100 labeling that will distinguish them. So this is a nice classic example of a granular cell tumor in the breast. Once you think of the entity, you can make the diagnosis. It's just not the first thing you think of in a breast mass. The challenge is when granular cell tumors are more spindled than they are epithelioid. And here's a breast needle biopsy where we see a very hypocellular stroma. And when we go to higher power and we scan the areas, really, there's almost nothing remarkable. It's brightly eosinophilic collagen. In some areas at higher power, you can actually see these linear rows of cells that appear to have somewhat pale granular cytoplasm, but it's extremely subtle. Here you go into this area, you say, oh, okay, maybe I see these slightly granular cells here. Here I can kind of squint and make out a nodule, an aggregate of the cells. But here I would characterize this as a really bland, possibly spindle cell proliferation, but I would think a lot about fat necrosis or scar with histiocytes. Keratin is negative. Inhibin is diffusely positive in these cells. So all of these spindled cells entrapped between the collagen bundles are in fact the cells of a granular cell tumor. You can see them all here. So I do include granular cell tumors in the differential of bland spindle cell lesions that have somewhat more abundant cytoplasm. And again, because they're S100 positive, the differential, depending on the morphology, could also be a schwannoma or neurofibroma, and indeed granular cell tumors are thought to be derived from pit folders. The last case I'm going to bring up today is this lesion here. And I always feel that it's important to mention this lesion, which in this particular case is occurring in the superficial dermis of the overlying breast and extending down into the deeper nipple parenchyma, where you see the smooth muscle bundles here, and even down into the breast parenchyma. So I see lesion going around these large ducts. From low power, this lesion is very hemorrhagic. We see a lot of extravasated blood. And as we go to higher power, we see these elongated spindle cells, which in some areas look vasoformative, that they may be forming these vascular channels, some of which contain red blood cells. And some areas, they form these almost solid nests of spindle cells. Marked nuclear hyperchromasia and mitotic figures are not difficult to identify. This is an example of a post-radiation angiosarcoma that's occurring in a patient who had a previous lumpectomy radiation for ductal carcinoma in situ. And this this is an example of a primary breast sarcoma, although this is in a way, it's a secondary sarcoma in this case, as it's post radiation. As it's vascular, it will label for vascular markers which include CD34, CD31, and ERG. Particularly on core biopsy, when you have a small sample, and you may not be seeing everything, and even on excision, it's still worthwhile to rule out a metaplastic carcinoma that may either be acantholytic or have hemorrhage due to procedural issues. So in general, these types of angiosarcomas are keratin negative, although it should be noted that some epithelioid angiosarcomas can show focal keratin. Now, the post-radiation angiosarcomas occur in the superficial aspects of the breast, in the dermis, and then they'll extend deeper. The primary breast angiosarcomas that are not post-radiation associated tend to occur in the deep breast parenchyma and in younger women. So those are sporadic primary breast sarcomas. They will label the same as other vascular neoplasms. And really the most important thing here is adequate local control because they are quite locally aggressive. And this entity should be kept in mind, not only in patients who have received prior radiation, but also in younger women with actual parenchymal breast cancer. Right, so I think I'm going to stop there. It's really been a pleasure leading this pathcast. Are there any questions at this time?
Yeah, we have one more question.
Sure.
So the question is, can we differentiate malignant phylloides tumor where no low-grade component can be identified from a primary undifferentiated sarcoma?
That's a very good question. And just to make sure everyone heard it, can we differentiate between a malignant phylloides tumor where there's no associated low-grade or leaf-like component and a primary undifferentiated sarcoma of the breast? By morphology and immunohistochemistry, the answer is no. I would recommend additional tissue sampling of the lesion to see if you can see a focal, residual, lower grade, or leaf-like component. Primary undifferentiated sarcomas of the breast are exceedingly rare, so chances are it's a malignant phylloides. Regardless, in that case, I would classify the lesion as a high-grade, pleomorphic, undifferentiated neoplasm, and in a note say the differential. A malignant phylloides of that morphology is going to behave like a sarcoma, and so clinically the patient will be treated as such. Malignant phylloides, if they metastasize, tend to go to the lung or metastasize hematogenously rather than to the lymph nodes like carcinomas do first. So practically, making the distinction is a little bit less important, but no, it's true, it may not actually be possible. Any other questions at this time? No?
I don't think we don't have any questions.
Okay. Yeah, really, it's been my pleasure. Thank you all for joining us today. Again, I want to reiterate, as Emilio said, that you can learn more about all of our educational activities here at Hopkins by visiting our website, which should be posted on the Pathcast site, but I'll just say again, it's pathology.jhu.edu/department/training/clinicians.cfm. And you can see our Surgical Pathology Unknowns conference online for free there, which is an excellent resource. And if you'd like to, you can also sign up for email notifications about our educational activities, such as additional Pathcasts. But again, thank you very much.
Thank you, Dr. Sumita Matthews. Thanks a lot. Emilia, would you like to add anything?
All right, thank you very much, Dr. Shmino Matthews, for that thorough overview of spindle lesions of the breast that I'm sure many of our colleagues will find very useful. I just want to point out that a lot of people have written in the Facebook and YouTube chat windows, and they're just thanking you for your impressive presentation. So thanks again. And at this time, it does not appear that we have any more questions. And I just want to remind our audience that today's lecture can be found at pathologycast.com. And just to mention, tomorrow we have Dr. Esther Diana Rossi, who is the co-chair of the Milan System for Reporting Salivary Gland Cytopathology, and she will be introducing the Milan System live from Rome in Italian. And that broadcast will take place at 8 a.m. local time, New York City, and local time 2 p.m. in Rome. And to learn more about the Milan System, please visit their website at milansystem.org. So with that, we hope you enjoyed today's session, and until next time, thank you.